thank Dr. Rishikesh for designing this IC, and I'm going to change tracks and move to vertical strabismus. A lot of them will be a little overlapping with my next speakers, but we will give a brief overview and they can take it from there. So my first case is that of a young child with a large right hypertropia of around 45-50 prisms and deficient infraduction in the right eye. So we had suspected some pathology on the inferior rectus, and we had ordered for a CT scan, and it showed an absent inferior rectus muscle in this patient. So we did a FDT, and it showed a superior rectus tight muscle, and we planned a superior rectus recession with a transposition procedure. Now, transpositions can be full tendon, but with a full tendon transposition, you tend to compromise the ciliary vasculature. So now we have mainly moved to no split transposition or the modified Nishida. So we planned a transposition to the absent inferior rectus, and post-operatively, we had a very good alignment with improvement in infraduction in the right eye. So when you operate on the superior rectus, remember, you recess around 10 millimeters as maximally, because beyond that you will get retraction of the upper lid. And upper lid retractors are intrinsically connected to the superior rectus. If you don't dissect the upper lid retractors well, you will get lid retraction. So you will have to dissect about 15 millimeters. Another structure which lies below the superior rectus is your superior oblique. So whenever you plan a large superior rectus recession, especially in DVDs, then you need to separate the superior oblique from the rectus and move the superior oblique away before you take the suture of the superior rectus or put the superior rectus on a hangback. The next patient was sent from our plastic clinic. He had a fracture floor repair, and post-operatively large ptosis, large hypotropia left eye, and no elevation in the left eye at all. They sent us this patient with a lot of hope, thinking that we will correct this and they will again do back the ptosis surgery. We found FDT tight on both superior rectus and inferior rectus, and on table intra-op there was extensive fibrosis around the inferior rectus muscle. Post-operatively, this patient looked like he has never been operated before. The entire money, we felt actually a little guilty for this patient because the hypotropia remained exactly like it was. There was no elevation improvement. So what really went wrong? You know that inferior rectus entrapment posterior to the equator limits depression, anterior to the equator limits elevation. However, in this patient, I think the inferior rectus and the surrounding areas were so fibrosed, and post-operatively the inflammation enhanced the fibrosis, resulting in our poor results. We could have actually put a little amniotic membrane to reduce the fibrosis around the muscle and expected a slightly better result. Now again, when you operate on inferior rectus, remember, like the superior rectus, inferior rectus also has intrinsic connections with the inferior lid retractors, and you have to dissect them well in order to prevent inferior lid retraction, which can be cosmetically ugly with an inferior scleral show. And you usually don't do more than 5 millimeters of inferior rectus recession for the same reason of lower lid retraction. When we do inferior rectus, tight inferior rectus surgery, we usually like putting permanent sutures because these inferior rectus move behind over a period of time and can cause late overcorrection. So usually we recommend suturing tight inferior rectus with permanent sutures. Moving a little away from this, we had a middle-aged gentleman with large hypotropia and exotropia and deficiency in elevation of the left eye. His muscles were all enlarged. This was a case of thyroid ophthalmopathy, and as you all know, they are acquired strabismus, they present with troublesome diplopia. So initially we had put Fresnel prism and tried to take him forward, but the diplopia persisted. So after a period of almost 1 month of stable angle, stable thyroid status, no activity of the thyroid either clinically or or radiologically, we took him up for surgery, did a lateral rectus recession and inferior rectus recession. Remember, the recession of inferior rectus was on permanent suture, and post-operatively we had a good alignment with good elevation of the left eye. So when you do plan surgery on thyroids, plan for recessions because they are restrictive strabismus. Plan a slight undercorrection, especially on the inferior rectus because of late overcorrection. Standard nomograms don't work for thyroid because the inflammation post-surgery is higher, subsequently fibrosis is also higher, and resections should be avoided because it's a restrictive strabismus. Intra-op, again, they are a very, very stretched muscle, so avoid yanking, otherwise you might get a ruptured muscle on table. Use these special hooks which can ease out the suturing so that you pull on the muscle less. The conjunctiva, because they are middle-aged, is friable and they are shortened, so when you close, keep the eye in maximum duction when you are closing. And prerequisites, remember, euthyroid status, clinically as well as radiologically inactive disease for at least 6 months with a stable angle over the whole year. Now, the next patient is that of a young child, 12-year-old with ptosis since birth. He had a 40 prisms of left hypotropia and limitation of elevation with ptosis. He also had a pseudotosis. He underwent, it is a case of monoocular elevation deficit, and we did a FDT on table, found the inferior rectus rather tight, so we planned a rectus recession of 5 millimeters. But since the angle was large, we again planned a transposition, and this time again also we did a modified Nishidas. Post-operatively, we had a good alignment. So whenever you plan surgery on MED, the FDT determines the plan. If it's a tight FDT, inferior rectus is recessed, and if it's not a tight FDT, usually we plan for transpositions. Again, NAP is the classical full tendon transposition, which we have almost given up because of the ciliary vasculature compromise. Partial tendon transposition can be done, but current favorite with all of us is the modified Nishida, where we don't split the muscle, we just take a permanent suture from the superior end of the muscle and suture it somewhere between the superior and the lateral rectus, around 13 millimeters from the limbus. DVD is another entity which is a little rare. We do surgical correction only when there is a cosmetically ugly DVD or we have a large DVD with an abnormal head posture. Usually it is associated with oblique dysfunction, but sometimes when oblique dysfunction is not there, we do the conventional superior rectus recession surgeries, bilateral usually, because otherwise it will become asymmetrical. If the DVD is bilateral, then asymmetrical surgeries. Superior rectus recession can be done with Farden, because if we do a superior rectus recession, conventional recession, we can end up changing the primary position vertical tropia. So recession can be reduced with a Farden so that the superior rectus is weakened in up case, or we can Y-split the superior rectus and recess it. Again, we can reduce the amount of recession if we do this. If it is with an inferior oblique dysfunction, we do inferior oblique anterior transposition. Usually the transpositions are J deformity transposition, where we keep this inferior oblique lateral to the inferior rectus insertion. The anterior and the posterior border is in the same plane as the inferior rectus insertion. We can do a MIMS modified Elliott Nankin transposition, where the anterior border is placed anteriorly along the border of the inferior rectus recession and the posterior border is behind it. Or we can do an anterior nasal transposition, where we transpose in front nasal to the inferior rectus insertion. Now, this is a patient of primary inferior oblique overaction with a large DVD in the right eye, asymmetric. He underwent a bilateral inferior oblique anterior transposition with a J deformity. Post-operatively, there was a limitation of elevation in abduction. It was a anti-elevation syndrome. The FDT is usually negative, and the anti-elevation causes contralateral overaction of the elevators, mimicking inferior oblique overaction. So modified Elliott-Nankin is actually more helpful in preventing anti-elevation syndrome. It is seen more when we do anterior transposition with the J deformity. This is a modified, this is the J deformity surgery where anterior posterior fibers are kept at the same level. So how to prevent anti-elevation in these anterior transpositions? We can modify it, we can anterior nasally transpose it, or we can split the inferior oblique in the form of a Y when we suture them lateral to the inferior rectus insertion. Inferior oblique again has a close proximity to the macula, so you need to avoid scleral perforations. Beware of multiple insertions. If you miss an insertion, you might have a late inferior oblique overaction after you have recessed the inferior oblique. And you need to remember not to use magnification while you're doing it. If you sever the tenons, you might have fat adherence syndrome. Now again, this young middle-aged lady has a right hypotropia of 15 diopter with the limitation of elevation in adduction. This was a case of Brown syndrome. Congenital Browns spontaneously resolves in majority cases, so we observe acquired Browns can also have spontaneous resolution with the anti-inflammatory, and Browns go into surgery only if we have a hypotropia persisting in primary gaze, which is cosmetically not very nice, or we have diplopia or abnormal head posture. The different surgeries have been proposed. Tenotomy is usually avoided. We elongate the tendon for congenital Browns with either a non-absorbable suture or a split tendon. We can use non-absorbable suture to elongate the muscle. Here we can see the surgery being done. We localize the inferior superior oblique nasal to the superior rectus insertion, and we put 2 permanent sutures and cut between the 2 sutures. So this is the permanent suture being put, and we cut it to elongate the superior oblique tendon. Split tendon elongation much easier. It is approached from the temporal aspect, which is why it is easier, and we put a Z incision and we elongate the tendon. Superior oblique again has the anterior fibers as intorters, posteriors as depressors. So in case of bifoveal fixators, we usually do a posterior tenotomy of the superior oblique instead of cutting the full fibers. So we have covered the different causes of vertical strabismus, the common ones. And to summarize, we need to select patients carefully. Our decision for surgery and what to operate is dependent mainly on FDT and FGT. We need to know the anatomy very thoroughly, use magnification, and set realistic goals for patients. This will go a long way in improving the alignment in vertical strabismus surgery. Thank you. I haven't done Y split of the superior rectus, but the oblique Y split is usually done to reduce the to slack the fibers over there. Ames group has done quite a bit of Y split of the inferior oblique when you are transposing it.
Would it bleed too much if you're splitting the inferior oblique?
Yes, inferior oblique. They probably. I have seen videos of theirs, nice videos, but they have neatly separated it, cut in between the muscle and sutured it. Something like our transposition, but they have cut it in the middle. I have not done it myself.